Buenos días con todos. Soy Carla
Good morning,
Sáenz.
everyone.
Soy
I'm
asesora
Carla
regional de
Sáenz, and I'm a
bioética de la
regional
Organización
advisor on
Panamericana de la Salud.
bioethics from the Pan
El
American Health
Programa Regional de
Organization.
Bioética
This
hace
program
parte del
on
Departamento de Evidencia. Buenos días con todos. Soy Carla
Good morning,
Sáenz.
everyone.
Soy
I'm
asesora
Carla
regional de
Sáenz, and I'm a
bioética de la
regional
Organización
advisor on
Panamericana de la Salud.
bioethics from the Pan
El
American Health
Programa Regional de
Organization.
Bioética
This
hace
program
parte del
on
Departamento de Evidencia e Inteligencia para la
IRBs
Acción en Salud.
addresses
En esta
actions
oportunidad,
related to
es un gusto
health.
darles la
So
bienvenida
it really
y
is a
antes de
pleasure
contar
to
más
welcome
sobre
all
esta
of you so that we
actividad,
can discuss in more
quiero
detail the
asegurar
activities
que todos
we're
saben
addressing.
cómo acceder a
Let me
la
just
traducción.
start off with
La,
some instructions as far as
usando el
accessing
signo de
interpretation services.
globo
Just
que
go
dice
down to the global
interpretación,
icon on
si
the
no
lower
lo ven
right-hand
en la
corner
parte de
for
abajo de su
interpretation. It should
pantalla,
be
pueden
on the
buscarlo donde
bottom of your
dice más
screen.
con tres puntitos.
Otherwise, you can go
Por
down
ahí
to the three
pueden,
dots,
si
and
necesitan la
there you can click
traducción
on if
del
you need
inglés al español,
interpretation from English into
pueden
Spanish or
marcar
vice
el idioma
versa. Just
español para
select,
escuchar todo
you
en
can select
español durante la
Spanish so
sesión.
that you can hear everything in
I'm going to make
Spanish
sure
during our
everybody knows
discussions.
how to use the interpretation feature. If you would like to listen to this session in English exclusively, please go to the little globe under interpretation, and you may find it under the three dots that say more, and click on English if you want to listen to every presentation in English. Como decía, soy parte del Departamento de Evidencia e
As I was
Inteligencia para la
saying, I
Acción
am
en
part
Salud,
of the
y
Office
esta
of Evidence
serie de
Intelligence
seminarios
in Health,
virtuales
and
sobre
these
temas relacionados con los ensayos
virtual
clínicos es un
seminars relating
esfuerzo
to
conjunto
clinical
del
trials is a
Departamento de
joint
Evidencia e
effort
Inteligencia para la
by
Acción
the
en Salud
Department
y
of
la Unidad
Evidence
de
and
Calidad
Intelligence in
y
Health and
Regulación
the
de
Unit
Medicamentos y
for
Tecnologías
the quality
Sanitarias de la
and
OPS,
regulatory
que
practices
hace
in
parte
the
del
area of
Departamento de
medicines.
Innovación,
This is
Acceso a
part of
Medicamentos y
the
Tecnologías
Office of
Sanitarias.
Access to
En esta
Innovations
oportunidad,
and Health
nuestra
Technologies.
sesión
So,
será
on
sobre
this
la
occasion, we're
política
going to
de
be
revisión
discussing
ética
the
única de
policies
los
on
Estados Unidos.
the single
El objetivo de esta
institutional
sesión es
review
escuchar sobre la
policy. So we're going to be
implementación de
looking
esta
at the
política en Estados
implementation of
Unidos,
these
entender
policies
la
in the
política, los
US to get a better
desafíos que supuso
understanding
su
about the
implementación y
challenges and
las
opportunities,
lecciones que nos
as
dejó,
well
las
as
soluciones
lessons
a los
learned
desafíos encontrados,
in
con
addressing
miras a que
many
en la
of the
región de las
challenges
Américas
encountered,
podamos
so
construir
that throughout the
sobre esta
Americas we can
experiencia de
successfully
aprendizaje.
build
Antes de
upon this
presentar a nuestro primer
successful
panelista,
track record.
quiero
So before I
invitarlos a
introduce our first
visitar
panelist, I would
la
also invite
página
you
web
to
del
review,
Programa Regional de
review
Bioética
the
de la
webpage
OPS,
on the
donde
PAHO's
ustedes pueden
site on
suscribirse a la lista ética de la
IRBs. You can
investigación
actually
y
enroll in
además
that
pueden
list if
ver
you'd
la
like. You
grabación
can
de las dos
also
primeras
see the
sesiones que
recordings, listen to
tuvimos
the
como
recordings
parte
of
de
the
esta serie
first two
sobre investigación
discussions that we had in this series
sobre
on
investigación con animales y sobre comités
research
de
working
datos
with
de
animals,
seguridad.
as well
Y
as
además
the
recibir, si se
IRB
suscriben a la
committee or
lista,
board.
pueden además
And you can
recibir
also, if
información
you get
sobre
into
el
the list, you can
siguiente
get more
seminario de la
detailed
serie, sobre el
information
que
about
diré
the
más al
upcoming
final de la sesión.
seminars that we'll also be
Y les vamos
addressing
a
at the end of this
compartir
seminar. So we'd like to
por
just
medio del chat
share
también
through
el
the
enlace
chat
para que se suscriban a nuestra
information
lista
so that you
Investigación
can
Ética.
you can subscribe to our
Nuestro
list.
primer panelista
So our
es
first
el doctor
panelist
Jaime Hernández,
is
que
Dr.
tiene una
Jaime
formación en
Hernandez,
Derecho. Él, y
who
perdón, pero
is
paso al
an
inglés
attorney
para hacer
by
la
training.
presentación
And
más
let me
fácil.
just
He's a
switch
public
over
health
to
program
English.
analyst at the Office for Human Research Protections, OHRP, from the U.S. Department of Health and Human Services, and with whom we have been collaborating for many really important initiatives, including the international compilation for standards for research with humans. Adelante, Jaime.
Thank you, Carla, and thank you, Sarah, and the Pan American Health Organization team for putting this together. It's a pleasure to talk to you guys today. I'm going to present. Oh, I have to share my slides. I thought I had done that. Just give me 1 second. I'm going to present today about the Department of Health and Human Services single IRB policy. I am cognizant that in many countries the term IRB doesn't mean anything. The IRB is only in the United States because that's what the regulations called it. But when I say IRB, it's an ethics committee, panel de revisión de ética. But it's difficult not to call it IRB because the policy, the regulations are written for single IRB, so it comes up in every sentence. So it's different to not to call it anything else. First of all, mandatory disclaimer for federal employees that whatever I say today is my opinion, and it doesn't really bind the Department of Health and Human Services or the United States government. And then I also want to let you guys know that OHRP published the draft guidance last year about the single IRB mandate in the regulations. I am including here the link to the draft guidance. SACAR is a panel, an advisory panel for our office, the Office for Human Research Protection, that in English we call it OHRP. And SACAR is our advisory panel, and they have provided us with some recommendations about the single IRB policy, and also including a link to the public comments that we received when we published the draft guidance. Now we're taking in those public comments, we're taking in the recommendations from SACAR, and we are revising the guidance to publish a final guidance hopefully soon. So the regulations for the Department of Health and Human Services can be found in the Federal Register at 45 CFR 46. And Section 114 is the section for cooperative research. It says that a cooperative research project are those projects that are covered by the regulations that involve more than one institution. And, and then in the second part says that any institution located in the United States that is engaged in this cooperative research must rely on the approval by a single IRB. Everything that's highlighted in red is because I'm going to explain a little bit more what we mean by that. First, the projects that are covered by this policy. In order to be covered by this policy, the project must meet the regulatory definition of research, and I'm including in little letters the citations so you guys can look at it later. But it's not research in the colloquial sense. There's a definition of research in the regulations. So it must meet the definition of research. It must involve human participants, and there's a definition for that in the regulations as well. And then the research has to be supported or conducted by the Department of Health and Human Services. What that means is, is either HHS, the Department of Health, HHS is doing the research for the research, generally. And that's when OHRP has jurisdiction over this research. Also, there's another 17 or 18 department and agencies that follow the same regulations, but they have their own Federal Register number. They have their own regulations. And if the research that you're working with is, for example, a research that is funded by the Department of Education, you should contact the Department of Education for their single IRB policies. Because the policies that OHRP promulgate are for the Department of Health and Human Services only. And then in addition to having the research having to be funded or supported by, supported or conducted by HHS, the research must not be exempt. The regulations contains a list of 8 exemption criteria. If the research is exempt, it means that it's exempt from the regulation, including the requirement for a single IRB, right? So none of the regulatory requirements apply because the research is exempt. Now, if the research is exempt, or if for other reason is not covered by the Department of Health and Human Services policy, The institution can always rely on a single IRB, right? Institutions are free to do anything that doesn't go against the regulations. So your institutions are always free to rely on a single IRB. It's just that HHS, the regulations don't require it. So that reliance is kind of like an extra regulatory reliance, and is not under the the jurisdiction of OHRP. Then what does it mean to that involves more than one institution? And this is important because we get this question a lot, right? There's, in general, right? This is a big generalization, but there's two types of multi-site clinical trials. In the first type, for example, there are three institutions, and all three of them are doing exactly the same work. Each institution recruits their own participants. They consent the participants, they obtain the blood samples, and then they undergo an MRI, right? That's an example. Each one of the institutions is doing exactly the same work. But there's also the case where, as part of the same study, one institution is doing the recruitment, another institution is doing the blood sample, and another institution is doing the MRI, right? But it's all part of the same research. In both scenarios, the institutions are subject to the single IRB mandate. They have to rely on a single IRB. So when it says that involves more than one institution, it's not the perfect kind of like multi-site clinical trial. It's like, as long as it is one research and involved is a general work, right? One research and multiple institutions working together, they have to rely on a single IRB. Now, what does it mean that the institution might be engaged in the research? This is a way more complex concept to explain today. I could give a 2-hour presentation on engagement alone. But what is important, and like the gist of it, is that if the institution is the primary recipient of money for research, of a grant to conduct the research, they're generally considered engaged. That primary recipient is generally considered responsible for everything that happens in the research. And then the other institutions, if their employees or agents collect information from participants through interactions or interventions, or access their identifiable private information for the research, or obtain the informed consent of the participants, then that institution is also considered engaged. There are some very important exceptions to this rule, and in this right here, I hyperlinked our engagement guidance, so in case that you guys want to look at it later. But what's the takeaway from this slide is that if you go back to the example I was giving later, in the bottom example, you will see that one institution is consenting the participants, the other one is collecting blood samples, that's an intervention, and the other one is doing an MRI, that's also an intervention. Is every institution that's pretty much directly working with the human subjects becomes engaged in the research. And then what do we mean by the institution must be located in the United States? If the institution is engaged in HHS-funded research that is not exempt, the institution has to comply with the regulations, regardless of where the institution is and regardless of where the research takes place. That means that the institution needs to have an assurance register with our office, OHRP. The institution needs to have an ethics review of the research by a committee that is registered with OHRP. There's like several requirements, right? But regardless of where the research is, the regulations apply. However, when it comes to the single IRB mandate at 114, it applies only to institutions that are within the United States. So if the institution is in another country, again, you can always rely on the single IRB. It is always possible if the institution thinks that is best, right? Like if they want to do that, they can, but they don't have to. The regulations don't require it. So let's give you an example. Let's say that an institution in California receives a grant from NIH to conduct research, right? So a PI in Florida will collect samples from in Florida and in Peru. And then another PI, another investigator in Peru will collect samples in Peru as well. And then all the samples will be sent to a commercial laboratory in Texas for analysis. When we look at this, the first thing that I note here is that the commercial laboratory, because they're providing only commercial service that they do every day without, they're not considered engaged in the research. And you can see that in the guidance that I hyperlinked earlier. You can see that's one of the exceptions that I was talking about. These people do this every day. It's a commercial service that they provide. So they're not, and they don't have any publication rights or any ownership over the research. So they're not considered engaged. So we don't even have to worry about IRB approval or IRB. We don't have to worry about anything for these people because they're not engaged. Now, the institution in Peru is engaged in research that is funded by HHS. So that institution needs to get the assurance and rely on a committee that is registered with OHRP. But the institution is not required to rely on the single IRB because they are in Peru, right? They can if they want to, but they're not required. Now, the California and the Florida institutions are engaged and they are within the United States. So they must rely on a single IRB. So one of those two institutions will be the IRB that reviews the study for both of them. Now, there's some documentation requirements for relying on the single IRB. The institutions must document that one is going to rely on the other one, right? One is going to rely, the other one is going to do the review. That has to be documented. Now, there's a tendency that everyone talks about reliance agreements. That's kind of like a term in the field. Everybody knows what a reliance agreement means. I like to use the word reliance documentation because the regulations don't require an agreement, right? The regulations don't require a formal contract in letterhead. What the regulations require is any documentation that describes the roles and responsibilities of each institution. This one is going to review the research. This one is going to do the reporting. This one is going to maintain all the records in their systems. You know, whatever distribution the institutions want to do is always fine. It's up to the institutions to distribute the rights and responsibilities, but it has to be documented. Now, this documentation, you could document the reliance for only one study, or you could say, for example, institution A relies on the IRB of institution B for all cancer clinical trials, right? So you do one reliance that covers multiple studies, right? Or you could do all studies. You could say institution A will rely on institution B for all of institution A's research, right? And you have only one agreement that covers everything. So there's no need to do one agreement every time that you get that you have a study coming your way. And second, the reliance documentation can take any form. For legal reasons, the most common thing that we encounter is the reliance agreement, a formal agreement, a contract between the two institutions. But it could also be, for example, an institutional policy, right? Like in the standard of operating procedures for that institution, it can say institution A will rely on institution B for the review of all cancer trials. That's a reliance documentation. However, remember, it does have to explain. It couldn't be just that. It does have to detail the distribution of roles and responsibilities. As long as the distribution of roles and responsibilities is clear, it could be an email. It could be inside the protocol, right? The protocol, when they submit the protocol to you, they submit the reliance documented as long as the roles and responsibilities are clearly delineated. Now, who decides which IRB will be the single IRB? Generally, is the federal department that is sponsoring the research. However, within HHS, let me clarify, because HHS is a very large agency that covers NIH, CDC, Center for Medicare, Medicaid Services. So within HHS, the sub-agencies, for example, NIH fund the research, NIH decides who's the single IRB. Now, the lead institution can propose the single IRB to the agency that's funding the research, and they can discuss it, right? They can see the plus and minuses and arrive at the decision together. And finally, I wanted to include, and I'm not going to go through this is for your information only, but this is on top of some HRP resources, and in the bottom, some academic articles about single IRB that I have found very helpful. And I just wanted you guys to have this information in case that you want to read more about that on your own. All right. Muchas gracias. Y bueno, I'll wait for the panel, and it was a pleasure to talk to you guys.
Muchísimas gracias a
Thank you very
Jaime por tu
much, Jaime,
presentación.
for that
A todos los que
presentation.
tengan preguntas, por favor,
Anybody
las
with
vamos a
any
responder al final.
questions, we're
Les
going to
agradezco que las
respond to the
pongan en
questions
la,
at the end. We ask
en
that
el
you
usando la función de
just
preguntas y respuestas
post
para
these
facilitar nuestro
questions
diálogo luego.
in the
Ahora
chat
es
box,
un gusto
the
para
Q&A.
mí presentar a
Now
Holly
it's with
Taylor
pleasure
y
that
cambiar
I
de idioma de nuevo.
introduce Holly
Holly
Taylor.
Taylor is a public
Holly-
health scholar, and she's a research bioethicist in the Department of Bioethics in the Clinical Center of the U.S. National Institutes of Health. Prior to joining the Department of Bioethics, she was an associate professor at the Department of Health Policy and Management in the Bloomberg School of Public Health and core faculty at the Berman Institute of Bioethics at Johns Hopkins University. She has plenty of experience on research ethics, and we're happy to have her with us. Go ahead, Holly.
Thank you, Carla, and thank you also to Sarah and to PAHO for inviting me to participate. So I'm very appreciative to the first speaker, because he has sort of given you a lay of the land, and I'm going to dig deeper into that land. Before I do that, though, I too have a disclaimer. As Carla said, I work at the National Institutes of Health, but I work in the Department of Bioethics, which is basically an academic department. I don't have any role in policy making. I am a social scientist, very interested in policy, and a lot of my research is in the area of policy as it relates to human subject research. So really quickly, I'm going to orient us to what I'm thinking of as the review process. I'm going to talk a little about what has changed with this new policy and for whom, talk a little about implementation, and then some barriers left to overcome. So just to make sure we're all on the same page, I want you to imagine, and I'm guessing that many of you don't have to imagine much, that you are a research ethics committee at an academic medical center. And the first thing that the Research Ethics Committee does is an initial administrative review. So the investigator sends in their documents, research plan, consent forms, etc., and there is an administrative review by that office. The next thing that happens is that that package goes to the Research Ethics Committee for human subject review. They will deliberate about the project, come to a decision, and relay that decision to the investigator. I also want to say that I'm not going to be talking at all about continuing reviews. I'm really talking about the initial review of a protocol submitted by an investigator. Now, as the previous speaker mentioned, there is a new policy for the Department of Health and Human Services. I'm going to work backwards just a little and say that prior to that, there was also a policy adopted by the National Institutes of Health to require a single research ethics committee of record. And another way to say that is we had a little warning, for lack of a better term, that this type of policy would become national. At the NIH level, it meant that all NIH protocols had to follow this. Now with HHS having the policy, it's more, it extends to more research at academic medical centers. And I just want to point out that that was in 2018 and 2020. As with most policy, we're really at the beginning of seeing how this policy will affect sort of the day-to-day implications for individual research ethics committees. So some colleagues and I, in advance of the NIH policy becoming formal, and also before the HHS policy became formal, we looked at the comments submitted by the public and basically organized those in order to identify the concerns of the research community. And so we looked at, for the NIH policy, 176 comments. That means 176 individuals or organizations submitted comments, and about 65% of them were positive as it related to the implementation of this policy. But they had some concerns. And I'm just going to share a couple of those with you. The first is the criteria for selecting the single research ethics committee. And as you know from the previous discussion, there is now sort of a policy for that. But there weren't any, and are still not any, minimum requirements for selecting that single research ethics committee. And we have, and I'm guessing some of the institutions that you all represent have accreditation. And there was a suggestion that AHRPP accreditation would be a proxy for picking the single research ethics committee. That would be one criteria to use. Another big concern was the delineation of investigator, research ethics committee, and institutional responsibilities. And you've heard this term reliance agreement, and Dr. Beer is going to tell us all about a way that many of the issues regarding reliance agreements have been addressed here in the United States. But there was a lot of concern before the policy was implemented about how all of this was going to happen. What if there's non-compliance? Who's responsible? Who's going to be in charge of making sure we all hear about the adverse events that are happening across sites? A couple of other things. One, the cost of implementation. And I'll sort of say, as one of the points that is true about this implementation, is that we have seen a move towards purchasing research ethics committee reviews from private research ethics committees in the United States, in part because the policy allows for the charging of those costs, but not costs to build the infrastructure at the academic institution. So if your institution was identified as the single IRB of single research ethics committee of record, there's no way for you to take on that responsibility and also receive some funding for that. Big concern about the consideration of local review. So imagine a clinical trial where there are 10 local sites and one single research ethics committee identified as the single IRB of record. These 10 sites are across the country, and there's a concern about how do local concerns make it to that single research ethics committee. Just going to move forward. Now, in advance of the HHS policy, there were also some opportunities to get public comments. And again, just to give you a sense of how long something like this can take here in the United States, the advance notice of rulemaking from the Department of Health and Human Service came out more than 10 years ago, right? We're almost 15 years ago. And then there was a notice of proposed rulemaking, which also sort of gave people an opportunity to look and see what was going to happen. So similar to the work that my colleagues and I did in advance of the NIH policy, we looked at the public comments regarding the HHS policy. And you will be not surprised that there are some similarities. So the first thing I want to say is that compared to the NIH policy, only about 27% of the commenters of the 275 were positively oriented towards this new policy. And I'll mention really quick, one unique thing about this policy was that there were actually about 1,500 comments, and we had to go through all of those and identify the 275 that had concerns about the single IRB. So that reflects the smaller group. So almost half of them were concerned about this local, losing the local perspective. Regulatory and legal liability, again, as it relates to who's liable if something goes wrong. Frustration, there was clearly frustration with delays caused by multiple reviews and wanting there to be some solution, but measured. There was a concern that changing the policy is just going to set off another set of potential delays, and also some question about this idea of who's going to choose who the single record rec is going to be. A couple of other things that I want to highlight with my remaining time. So there are some remaining concerns about the implementation of this policy. And I want to talk a little more in depth about a couple of them and then just share a couple more, and happy to talk further about them. So the first thing I want to talk about is the coordination of what I'm calling ancillary reviews. So again, imagine you are at an academic medical center, you have a research ethics committee. The job of that research ethics committee, as I talked before, was to do some administrative review and some human subjects review. This policy only relates to the human subjects review. That's what's in the green box there. So if you imagine before this policy in the United States, and this was a big push towards a policy, if you were doing a study and you had a coordinating center, for example, and 5 local sites, that meant, and it may still remain true for many of you, that each of the sites, as well as the coordinating center, had to get review and approval by their local IRB. And so that meant that there was 1 review for the coordinating center, 5 local IRB reviews, and 6 IRB reviews total. That said, it's pretty clear, or I want to convey that it's pretty clear because the blue lines are pretty direct, right? Each institution is a single institution taking care of their own review. Now, if you take that green box out of the equation, meaning that you've now given the human subject review to that single IRB of record, you end up with all the local sites still having to do their ancillary administrative review. So pharmaceutical review, biosafety review, conflict of interest review, all sorts of things that office continues to do. And now the thing I'm sort of most worried about, or still have some concern about, is if you are an investigator at one of the local IRBs down at the bottom, you now have responsibilities to your IRB and to this single research ethics committee. That means that you have to keep track of to whom you need to report. So if you're an investigator who is working with a number of different clinical networks, all of that multiplies. Now, that doesn't mean that it's not a good plan per se to centralize that review of human subject research, but it doesn't eliminate the administrative burden for the local institutions and may even increase the administrative burden for the investigators and may sort of shift some of the attention of the local institution administration to issues that are related to how their local investigators are engaging with external institutions. I want to bring up one other issue related to this. So, as was mentioned, I'm at the National Institutes of Health, and a lot of work that the National Institutes of Health funds are large, coordinated clinical trials. So imagine a master protocol, right? An executive committee in heart disease or HIV or tuberculosis or COVID, you name it. They get together and create a master protocol with the intention of then having that master protocol implemented at local sites. And that master protocol is very much developed by investigators affiliated with this network. And there's usually a PI for each master protocol. And what happened prior without the single REC of record, there'd be a master protocol that would go to the local site. There would be a local IRB review. The trial would then be ready for implementation. Now, the clinical coordinating groups are in a position of having to figure out how they're going to review the master protocol for human subjects oversight. One way that they are doing that is bringing in a commercial research ethics committee instead of saying, oh, Harvard University or Johns Hopkins University is going to serve as the research committee of record. We're going to purchase the review from a commercial organization. And an important thing that means is that cost is now borne by a system that wasn't ready or didn't have those funds allocated, and to an administrative system that was out of the loop in terms of human subjects review, right? So if I go back to the previous slide, that master protocol didn't see an IRB until it went to the local site. Now it's being pulled into the administration of the coordinated clinical trial. So while it does perhaps streamline the dissemination of the approval and the dissemination of consent forms, it's a time and cost shift that it's not clear it actually is more efficient. The likelihood is that it is, but we're just a couple of years in. The other thing I wanted to mention is that if this network study includes international sites, that international site is outside of this master protocol review by the single research ethics committee, and they can do their own local review if that's what they would prefer. But the local sites in the United States don't have the option to do a local review. So I just want to highlight a couple more concerns. And these come from some of the articles that were shared earlier, and I have a reference slide at the end for those of you who might be interested in following up. So one thing that is true, but we don't really have a sense of how often it goes on, is that even though the local site is allowed to rely on the review by that commercial IRB or by the single IRB on the previous slide, there's some empirical evidence and some just, anecdotal evidence that local IRBs are also conducting shadow reviews of their, as it relates to human subject research, right? And that totally defeats the idea that we're trying to streamline and minimize the number of reviews that are going to happen. And there's some concern that that might relate to a lack of trust in this single research ethics committee. There's also some remaining concern, I think there is, about what sharing the local context means. My sense is that a lot of the local context that is shared, again, by those local sites that are implementing the study is, here are some laws in my state, here is some site-specific policy. It's not clear to me that there is a good way or a standard way or a, empirically informed way to get information about the community of individuals that may be the source of participants recruited for the study. To me, that is what local context is. It's also, of course, laws and policies, but I think we're missing that piece. Another big challenge is lack of interoperability across electronic submission systems. So I'm going to assume that those of you who are affiliated with research ethics committees have migrated to an electronic system. Frankly, paper would be easier, maybe at this point, though there'd be a lot of copying going on. But if let's imagine I'm at Johns Hopkins still, and I want to communicate with Dr. Beer's IRB at Harvard, we can't do that easily because we have purchased a system or tailored a system to our needs. So in order to gain some of that efficiency, this is going to be a challenge moving forward because everyone has sort of built their own internal system. So with that, thank you very much. This is my email address if anyone wants to reach out and follow up. And with that, I'm going to hand it off to Dr. Beer.
Thank you so much, Holly, and welcome, Barbara. Barbara is trained as a physician, and she's a professor of medicine at Harvard Medical School and a hematologist oncologist at the Brigham and Women's Hospital there. So she's the director of the Regulatory Foundation's Law and Ethics program at Harvard Catalyst, and director of regulatory policy that includes Smart IRB, about which she'll talk today. So she co-founded and now leads the multi-regional clinical trial center at Brigham and Women's Hospital and Harvard MRCT Center, which probably many of you have heard about, also because she's participated with us at a prior event. Welcome, Barbara. Great to have you.
Thank you. Thank you, Carla. Thank you, Sarah. And thank you, PAHO. And thank you to the participants and people on the call. I have to say about the last two presentations, yes, I agree with essentially everything that was said. And today I'm going to be talking to you about how we've approached the challenges, many of which were outlined by Holly and reviewed by Jaime. So about 15 years ago, we started, I am at Harvard. We have 19 separate Harvard affiliated institutions, and we were all doing our own IRB review or Research Ethics Committee review incredibly inefficiently, and wanted to see if we could establish a way of communicating with each other and making the process easier. So that's what has been developed and what we will now talk through because it's become the national program. So I want to just explain that we started this work at Harvard in 15 years ago. We've been funded from the NIH to continue this work on behalf of the nation since 2016. And now we have a contract with NCATS that I lead. So the idea here was to appreciating all of the cumbersome elements about creating an agreement and understanding those policies and who would do what, where, and when, and trying to figure out how we're going to do some of the operational issues that Holly described. Adverse event reporting, for instance, who's responsible for that investigation? We needed a way of thinking about this nationally, and Smart IRB was born. It is a national IRB reliance network that I will describe. We have support for that effort through a contract, as I mentioned, to Harvard on Smart IRB, working with the NIH primarily, but soon to be broadened. We do a lot of education and training, and we are specifically focusing on how to harmonize the review processes as well. And the core elements of this network is the agreement itself. It is a single IRB authorization agreement. You sign once, and you can rely or review on behalf of any other institution with that as the background authorization agreement. You don't have to sign it again. I have to say, in the old days, we would probably sign about 5 or 6 a week, which took a long time to negotiate with each institution. All of that cumbersome administrative work is now gone for those who use Smart IRB. We do have a set of standard operating procedures which clarify the roles and responsibilities, as Jaime was saying. But it's flexible. If you want other SOPs, you can use those as well. We have a series on the right of ambassadors across the nation who really are expert at making this work and who are there to help institutions and investigators and individuals understand the network, understand how to do this, and to help answer specific questions. And we have committees supporting each of these. And then we have informatics. There's a Joinder platform, so you join the IRB. There's a website which explains everything, and then there's a reliance system which helps document who's relying on whom, who the individual investigators are, who the point of contacts are, what the protocol is, and who is doing the review and reliance. So it started when we did this at Harvard, as I mentioned, and got together, I think, 8 of the institutions over 2 years of discussion, because we trust each other only minimally, I guess, to collaborate with one another, and got an agreement across those sites. We then sent that agreement to institutions in Texas, Ohio, California, and elsewhere. And each of them started to work on their local environments. And then we realized really that we are as likely to collaborate with a group, in Texas or California as we are across the street. This was all before the regulations that Jaime discussed, and before the NIH policy that Holly discussed. So 8 of these groups came together to see whether we could establish a national IRB reliance agreement. We had academic healthcare centers, universities, both private and public. We developed this, prototype agreement, sent it to 72 institutions, and got 3,000 comments back. And we diligently went through each one and then shared it with another 115 institutions, with the NIH and others, and established the first IRB agreement in 2016. Since then, more than 1,275 institutions have joined. That's in almost every state, all but one. We have institutions in Puerto Rico, and the NIH joined as well as the 800th institution. We are now revising the agreement today in order to accommodate institutions that are at the Veterans Administration, the VA, the DoD, the DOE, and other signatories to the Common Rule. So what is this agreement? First of all, it's across the US. It is for all clinical research studies. It's for all human participant research, whether expedited, limited review, or full board review. It can be used for exempt determinations, but it's not required to be used. If you want to use something else, you can. It's there if you want it, and it need not be there if you have an alternative, such as a common IRB that, you know, the NCI, for instance, hosts an IRB. And it's regardless of funding or funding status. So it's not restricted to federal awards. It's not restricted in any way. It's really there as to provide that background. It does require you to have a federal assurance. Jaime talked about an FWA. We're now broadening it so that you can have any of the federal assurances and participate. There has to be a quality assessment of the quality of either your IRB and human subjects protections, and a point of contact at the institution, because of course we're collaborating with people now that we don't know. It's not like working with people across the street. We don't know who they are, and we need to be able to say, you have to find the answer for that institution. There are some exemptions, but really it gets rid of this need to negotiate for each study without having an obligation to enter into reliance or to serve as a reviewing IRB. So it is flexible. There are standard operating procedures for clarification. You don't need to use those. If you want to use them, you can. But you can also define alternative SOPs if you want to for that study or for that institution. And the institutions themselves decide which SOPs and which roles and responsibilities they're going to have. Actually, SOPs, we define the roles and responsibilities. There's a lead study team that will operate as the coordinating center and basically coordinate the reviewing IRB, the relying institution or institutions, and then the two teams, the lead study team and the relying site study team. I want to make one important point. In the old days, the IRB, or the Research Ethics Committee, was really that office and group that did everything in terms of human subjects protections or human participant protections. It coordinated the ancillary review, made sure the contract was in place, made sure nursing was trained, made sure that that radiation safety was taken care of, that there was PI, investigator education, etc. A whole host of institutional responsibilities that were different than full board or IRB review itself. And what the policy at the NIH and in the government has done, and what we found, is that this transition to a single IRB review really required us to separate the functions that are intrinsic to the institution, who has oversight responsibility for their investigators and study teams and safety of their participants, from the IRB review itself. And that's what a lot of the work has been. So there's an IRB or an institution, the reviewing IRB, they have all the IRB oversight responsibilities. It doesn't mean the institution who is relying doesn't have to know something about the research at that institution that they're responsible for, But the IRB functions sit with the IRB of record. And as a principal investigator, you work with your institutions, Smart IRB point of contact, to determine, the arrangements and your responsibilities, and really look to that person and your relying institution. So we have a reliance system that is a single point of entry and a web-based sort of infrastructure tool to support this work. It communicates all of the email traffic and coordination so that you don't have to do that outside of a workflow environment, and it is the IRB of record. What's interesting is that there are about 11,000 now Smart IRB users. There have been 9,500 reliance determinations through this system, but there's no requirement to do this in the system. And 86% of those participating institutions are registered to use the website itself. At this point, we have almost everybody coming to a decision about reliance, a quarter within a week, 60% within a month, and 80% within 2 months. And that's inclusive of all the new institutions that are joining. At the onset of COVID-19, we prioritized those reliances, and we had the fastest that came through was 19 minutes of 4 institutions deciding to rely on one IRB of record. So we do think that this has helped with a lot of the administrative cumbersome issues. We do a lot to maintain communication in addition to an email newsletter and announcement. We have a monthly talk for an hour and a half on best practices, issues, and anything we're changing, a series of webinars, 3 regular conferences a year, and a set, as you can see, of people that will help. We also have a library of resources that we've developed. It's very deep and very sort of searchable and findable, and really do our best to maintain resources that are helpful to make this operationally easier for somebody. But realize that for many investigators, they're only going to do 1 or 2 protocols in a reliance environment in probably a year or 5 years or maybe ever. They're not going to be the experts. You need an investigator group that is and an institutional resource that's going to help new investigators to do this well. But that is the concern, and that is what we've found to be quite helpful in having ambassadors and also resources specifically for the study team. We have a harmonization steering committee that works through many of the issues that Holly mentioned. How do you do ancillary reviews? How do you make sure they're done? How do you make sure that you know what the issues are, and that all of that rolls up to the institution, and that even though there's an IRB review and approval, it doesn't get activated at your institution until those ancillary reviews are done. How do you do conflict of interest review at a distance? How do you audit studies subject to single IRB review? Because this is now an IRB that's asking for an audit 3,000 miles away. What is the continuing review process? What are the associated responsibilities with the review of study personnel at a distance? How do we deal with reportable events? When you report an event to an IRB, your own institution still needs to know about it. So how do you do fees and costing? What are the local contexts? We have each of these are worked through, and then our best practices and guidance are put out there. Everything is free. Everything is freely available. And anybody who wants to use this or translate the agreement and modify it, we're welcome and happy to help you do so. So we've mentioned this sort of transition from our work to the regulatory environment that required most multi-site research to be subject to single IRB. And in about 2 years ago now, FDA also released a notice of proposed rulemaking that said it might require single IRB. We're still waiting to see how that comes out. And we've got regular, I'm just going to click through so that we don't have to see this. We have regular meetings to harmonize processes and improve the collaboration through these educational sessions and resources, federal guidance on single IRB, and institutional experience, which we really rely on to make both the agreement and the materials that we provide better. But there are many bottlenecks or problems in local practices. First of all, the completion of electronic IRB submissions remains standard, even in single IRB research. And if your institution as a relying site needs to know about your protocol, they will likely make you put in at least some information into the institutional system. And at that point, it is duplicative for the investigators. We're working on that in the 3-year plan to have ways of creating that interaction and interoperability, but it's not there yet. We do need local compliance and tracking, and we need to formulate how the institutions and IRBs really relate to one another. And our current practices, at least at Smart IRB, don't allow us to develop metrics because there's no requirement to use this, and therefore it's an incomplete picture. And we're really working on reducing institutional burden. So the challenges are clearly increased research volume under new, changing, and multiple federal department regulations. I think that there are significant, certainly in the US, socio-political events and changes in local and state law that make it challenging to review at a distance. Our laws on transgender care or abortion-related issues are at the state level now, not at the federal regulation, and you need to keep abreast of the changes in state law. There are institutional constraints because of the costs, as Holly was talking about, and then there's this issue of interoperability. And I will say it's not only a national issue. There are international challenges to cooperation, some of which we probably have a model for how to decrease those challenges, but those challenges include delays, costs, and again, this issue of harmonization. But there are other challenges like privacy, confidentiality, security, data sharing, particularly with the growth of privacy laws. And then most importantly, challenges with respect in terms of the different cultures and expectations of countries outside of our walls, issues of reciprocity and benefit sharing that I still think need to be worked out, and many things that IRB review can touch on, but certainly don't control. And with that, let me thank you and open it up for discussion. And again, here's my email address, and happy to talk to anyone offline as well. Thank you.
Muchísimas gracias, Bárbara. Quiero invitar a
Thank you
todos
very
los
much, Barbara.
panelistas
I would
a
now like to
conectarse
invite
nuevamente,
all of the
a
panelists to connect once
prender su
again.
cámara nuevamente
Just
y
turn on your
presentarles
cameras.
también
I would
a
also
Sara
like
Carraceo del equipo
to
del Programa Regional de
introduce
Bioética
Sarah
de la
Carracero,
OPS.
She is from Bioethics at the PAHO organization, who's going to moderate the session. But before I offer the floor to Sarah, I would just like to highlight the significance of this discussion for the region, in particular for Latin America and the Caribbean, both regionally as well as the individual country level, how we're having the same discussions as to how to transition to reliance systems. How can we avoid unnecessary duplication of efforts in the review? But we're not going to sacrifice the rigor that is associated with this. We need to work in a more coordinated fashion, and that addresses some of the specific challenges mentioned by Barbara, in that if we assign each person, each organization, the tasks that they are supposed to assume. Sometimes people take on tasks because there's nobody else that will do it. But as the process evolves, and I think in Latin America and the Caribbean, we are transitioning in the process of the IRBs. So we can see that we look at, okay, these are tasks for the organization, the researcher, the regulatory agency has other tasks, and we need to get a more clearly delineate this landscape. But I'd now like to offer the floor to Sarah so that we can begin with the Q&A. Thank you, Carla. And thanks to all of our panelists and participants who've joined us today. Before we begin with Q&A, I would also like to just mention that you can post your questions through the Zoom Q&A box. Now, the first one has to do with ethics committees or IRBs. Is there any authority, central authority, any organization in the U.S. that accredits these IRBs and that they have oversight over these IRBs?
So there is a requirement to register the IRBs with OHRP. Registration is not accreditation, and there is no, if I can speak for OHRP, there's no expectation that OHRP is accrediting those that register. There is an organization called the Association for Accreditation of Human Research Protection Programs, AHARP, we call it. You heard about it briefly. That does accredit IRBs and human research protection programs. It is not required. There is no national accreditation. There is no requirement for certification or accreditation, which differs from many other countries.
Yes, Sarah, hi. I want to add to that Barbara already mentioned that there is not a requirement, but I want to highlight that point, that the regulations don't require any IRB accreditation, right? It's just not mentioned in the regulations. All that is required is that the IRB registered with OHRP, and then like what we check is the IRB requirements, like how many members, blah, 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 things like that, like the composition of the IRB, but there's no accreditation per se. And this is important in terms of single IRB, because when the policy went into effect, one of the first obstacles that I noticed, noticed because people started calling me on the phone and sending me emails, that some institutions don't want to rely on an institution that doesn't have an AHARP accreditation, right? AHARP is a great organization, but like the regulation doesn't require that the IRB of record to have any accreditation. Yet the institutions and AHARP accreditation is not cheap, right? And it's not. It's an administrative. You should see the institutions when they are going to be, because they're very strict when they accredit their IRBs. smaller institutions, rural institutions, small community colleges, smaller minority serving universities don't have the resources for AHAB accreditation. And they find themselves caught up in the like, well, I will never rely on you because you don't have the AHAB accreditation. And then they blame it on OHRP, but OHRP doesn't require it, right?
And I'll just add, given the thousands now of organizations that have signed on to the SMART IRB, I can't quote you, Barbara, but it was more than 1,000. There are only about 200 institutions in the United States that are accredited, and those are mostly large academic medical centers that can afford accreditation, just to emphasize Jaime's point. So it's not a universal, it's not something that all IRBs seek out. And but as I mentioned, it was sort of proposed as a proxy for a high quality IRB, but that clearly can't, capture all the different IRBs that haven't purchased that seal of approval.
Gracias por las respuestas.
Thank you for those responses. And then we have another question that has to do with the time frame for the review process. How long is this time frame in the single IRB? What is the time frame we're talking about?
So I'll give you an answer, and I'm sure that Jaime and Barbara also have answers. So my experience has been primarily with these large networked studies that are bringing the IRB approval into the overall administrative component of the review. And there are a lot of moving parts. So it's getting better, but early on, it took almost a year for the IRB process to be identified, for it to go to the commercial IRB, for there to be some, negotiation, et cetera. That has compressed over time. But, right, the idea is that time is not time spent at all the local IRBs. So imagine if it took 2 years for 10 sites to seek approval from all of their local IRBs. Now there's just one that even if it took a year, it's half that time. And I'm sure Barbara has more examples from the more sort of regular IRB setting.
So I would say it's a complicated question because there is the IRB work or the HRPP and institutional work to develop those reliance arrangements. And then there's IRB review. And in the old days, it took months to do that arrangement. Now we've got that down. That doesn't speed up the IRB review. Okay. And it shouldn't speed up the IRB review. The IRB should take whatever time it needs to make sure that they are doing the job that they are empowered to do, which is to protect human participants and minimize risk and all the rest of it. It does eliminate the sort of issue of once 10 IRBs have reviewed it, now they have to go back to each other and continue to work together until they have one protocol and one consent form that everybody's aligned on. So that's clearly simplified. The other thing that's been incredibly more efficient is continuing review, because you only have one review and you only have one group making the decision and then communicating it to everyone. But, to get it in place, to have those efficiencies is not trivial. Jaime?
Yes, I'm glad to be hearing all of that from you guys because like Holly said, it started slower than I expected it. And I thought that it wasn't going to be like that because the NIH policy had been around for a while, right? So I thought that with like time to learn, but no, they started very slow. And a lot of institutions complained that any amount of time that they were saving on approving the protocol, they just were allocating it now to the administrative process of getting all the reliance agreements and all of that before. So now it's getting a lot better and it's picking up speed. The one thing that I want to mention is the shadow reviews that I think it was Holly, the one who used that term, that so we cannot prohibit the institutions from doing them, right? The regulation, we're not there to prohibit things, right? Like they met the regulations, they rely on a single IRB. They can read and reread and reread that protocol as many times as they want, but sometimes they refuse to let the study go forward with the main IRB until they conduct the shadow review, and that's defeating the purpose, right? These shadow reviews are like, you once you sign the reliance, you're signing your trust in the regulatory expertise of that other IRB. And one final point that I wanted to make is when the federal department of agency that picks the single IRB and the institution that's getting the main grant are talking to each other to determine who's going to be the single IRB. Workload is one of those things that maybe they should talk about, right? Maybe Barbara University is backed up, so at least for this protocol, like Holly University is going to be the single IRB, even though Barbara University is like the one who's getting the grant, right? Like that. All of those are things that can be worked out.
So let me just add a couple of things. First of all, Jaime, there's no requirement that, as you said, that the grantee institution is the IRB of record.
Correct. No, this is very important.
What we do is basically say the default, because we don't want IRB shopping. We don't want, investigators to go to the IRB they know is going to be easiest on them. What we don't want is IRB shopping. So we say the default is the institution of the lead PI, the overall investigator. But there's no requirement that institution take on that review. Of course, it's in federal grants, it's with the understanding of the funding agency. And particularly there are times where different IRBs are better at different reviews, such as outsourcing when there's prisoner research, or where you're dealing with a particularly vulnerable population that one IRB has experience with. That's where I think it's very important that people retain a sense that flexibility is also a very good thing. The other thing I'll say is that there are shadow reviews and shadow reviews. So it is absolutely, to Jaime's point, ridiculous for an IRB to sit down who doesn't have authority and at full board review a protocol again. But there has to be some way that the institution knows about the research that it is responsible for. And that investigator and study team can't go away or around the institution, because the institution has knowledge about what the training is of and competency of that investigator, B, whether they've had trouble with them before, C, whether their institution can support the nature of the research that is being proposed, and 4, once there's a problem, they need to be able to step in. So I think there is a responsibility on the part of institutions, but it's not a shadow IRB review. It's at a different level. And that's this issue of segregating the HRPP from the ethics review itself.
That's an excellent point, yeah, especially for IRBs that have a very broad reliance agreement. Because if you're doing reliance protocol by protocol and PI tries to go around you, you're going to get a reliance agreement to sign and you're going to realize that the PI didn't come to you. But if you have like a very broad reliance agreement, like you may not be aware of everything that your investigators are doing. And I mean, it's obvious that for many reasons, liability, responsibility, that institutions want to be at least informed of what investigators are doing, right?
And I'll just add that so I do have colleagues at a number of different IRBs in the country, and one way that they address this concern, Jaime, is if I'm the institution, I require that a investigator who's planning to participate in a project where the plan is to rely on an IRB other than that local IRB, they are required to come and have a conversation about the plan, have that plan approved before it's submitted, engage in a conversation about what their roles and responsibilities are as it relates to the IRB at the local site, as well as the single IRB of record. So another way of saying that that's yet another layer of work that has to be done and education that has to be done that in the long run may make things more efficient. But there's an awful lot that has to go on to make sure everybody knows who's doing what and who's responsible for who.
Gracias por las respuestas. Hay varias preguntas
Thank you
sobre estos
for those
acuerdos, pero
comments.
antes de
There's
ver
several
cada uno en
questions
específico,
relating to
quería
these
tal vez
agreements, but
que de
before we get
nuevo
into the
resalten
details,
y
I would like
nos
to
vuelvan a explicar por
maybe
qué es tan
we can address
importante estos
why
acuerdos.
are these agreements
En
so
muchos países de
important
la región
in
de
many
América
countries throughout the
Latina y
Americas,
el
Latin
Caribe.
America and the Caribbean.
Muchos comités
There are many
revisan
committees that
la
review
investigación de
research
otros comités sin estos acuerdos
without these
legales.
agreements, without these legal
¿Por qué es tan
agreements in
importante
place.
tenerlos?
Why is
¿Para
it
qué nos
so
sirven? ¿Cuáles
important
son
to
las
have these in
implicancias de
place?
tenerlos?
What are the implications when
From
you
the perspective
don't
of the
have
regulatory
these?
office is because that's what gives OHRP the compliance teeth to figure out what happened in case that there is a lack of compliance case, right? Like a violation of the regulations. We need to be able to see who was the one who had to send this report and didn't send it, right? Because it's very difficult to show up at the IRB that may be in California and tell them, oh, you are responsible now for something that the people in Pennsylvania didn't do. But they're like, we thought that Pennsylvania was going to do that. And, that back and forward later, it just makes it a lot more clear, like who's going to do what. And the other thing that I think is very important is that let me back up. The other thing that I think is different from many ethics committee relying in Latin America is that I don't know. I'm gonna pick on Peru for lack of a better example, right? Like there may be like 20 IRBs in all of Peru or something like that. I'm totally making up these numbers, right? But like there may be 20 IRBs in Washington D.C. alone. That is only like 5 square miles, right? So it is easier for when the number of IRBs and institutions are small, it's easier for everyone to be part of the same kind of like IRB professional community. They all know each other. It's easier to rely like that. That when an institution is, again, in California, is working with one in Pennsylvania, they never met each other. They don't know who they are. And there's not that kind of like, let alone if you're doing like a multi-site clinical trial with like 15 IRBs all around the country, how do you keep track of who's going to be doing what, right?
So another way to think about that is that back in the 1970s, early 1980s, the IRB in the United States was born, quote unquote, in a local institution. And so that means now in 2024, there are 3,000. I don't know, Javier, but we've been behind me the number. Like, let's say there are 3,000 IRBs that have a federal-wide assurance. So it's just been a very independent process, and I don't know enough to say anything, but maybe this is true, is that it may also be that in some of the countries you guys are from, there's more regional collaboration. You could imagine that the United States in the 1970s said, hey, you know what? Maybe one IRB or 12 IRBs per institution is going to be too much. Let's have a regional organization and have 10 IRBs and, 100, whatever, right? All to say, part of the reason for our being in this position and needing a policy to address this, multiple reviews of a single protocol is that, we were all raised in very independent institutional settings.
Yep.
But Barbara has told the story of what they did in Boston, right? It's like, holy cow, we work together all the time. Maybe we should do some additional coordination. Those types of relationships have only, certainly in the 2000s. So it's sort of bucking against some of the history as well.
So, and there are many different models for ethics review that I just want to mention. One is the one that we have in the United States, where there are probably, what do you think, 5,000 or 6,000 IRBs, something like that. It's not few. It's not 20. There are countries who have a national ethics committee who have oversight, particularly for investigational trials or in interventional trials. There are other sort of qualified country IRBs that get assigned by the country depending on what they actually are going to review. So particularly expert at pediatric or cardiovascular or infectious disease. All of those work. It just depends on making sure it works for you. And this is a way, the way this Reliance agreement and Reliance network is for the kind of complexity and the volume of protocols that we see in the US. That's not true everywhere. And one might want to, think through whether student research, for instance, is very different than interventional research with drugs, devices, vaccines, etc. One might want to think about whether social behavioral research needs a different kind of review than we have. One might want to think about whether genetic review or data reviews actually expose different risks than we see with drugs, devices, vaccines. And when we're talking about countries collaborating together, I'm not sure that Reliance is the best method because both countries need to be, or many countries need to be then very familiar, not only with the laws and regulations of the other countries, if you're assuming responsibility for it, but also for the culture and the differences across those borders. And one might want to think about, for instance, joint review, where people come together to review collaboratively, identify the real issues that are at stake, and then come up with a common way of thinking about it. That's what we're, a model that's being piloted in Africa, for instance.
Yeah, Barbara, can I say to that, you almost read my mind with the joint review comment that you made, because going back to the local context, and I want to also second Holly, in like, no one has really entirely defined what local context is. It seems like everyone is talking about one aspect of locality, but like there are ways to deal like with local context that if you look at this is not in the regulation. Let me first say I'm taking off my OHRP and keeping my bioethics hats, right? But like you could do a kind of like joint review, right? If you are the single IRB, and there's 7 sites in 7 different states. Well, maybe the IRB chairs of all those or the HRPP directors should have a meeting, and everyone should sit around and talk about this and voice their local context. Another thing that the regulation allows, for many years, the regulations have been very clear that IRBs may bring consultants into the IRB when the IRB thinks is necessary for filling up, gaps in the knowledge. Bring somebody local from the place where you have a local context issue. Bring them into the IRB meeting. They could, I call them whatever you can call them. Like a guest IRB member, like all of those flexibilities exist under the regulation. Like, they may not be able to vote, but by the IRB before voting, it's getting the information that it needs.
Right. And that's very much the model that we, quote unquote, the United States has adopted when it relates to conducting research in Peru, for example, right? If we're a local IRB in Bethesda, Maryland, we don't have the expertise that we might need to appreciate the local context of the place in Peru. So we have the ability to bring an expert in to do that. And that's the norm when we're dealing with different countries. It's not the norm, and maybe it could be when you're talking about Baltimore or Dallas or Los Angeles.
Correct.
That's not the norm yet. And I
But
think
it could be, right?
Well, it could be, but again, just so the administrative challenge of getting 8 IRB chairs in the same room, virtual room at one time, like that in itself would take a lot of time. But that said, right, one thing that I think we don't do enough of, or could invest time and energy in, is say there are some trials where the absence of local information means we cannot do an appropriate ethical review. There are lots of trials where we don't need that level, but we're not making a distinction between the research that's happening in this place, this type of research, et cetera, versus 10 trials doing a phase 2 oncology trial. That's kind of bread and butter, as it were, in an oncology center versus a community-based project based in Dallas, Baltimore, and New York or something.
Yeah.
Gracias. Han tocado varias respuestas.
Thank you. We've heard a number of answers to some of the other questions, but maybe we need to focus on some more practical aspects about the agreements.
¿Cuáles son las principales responsabilidades?
Which are the chief responsibilities and obligations spelled out in the agreements? And how is oversight managed for those investigations that are approved under the single IRB system?
So, from the perspective, and I think Barbara mentioned some of these, the main responsibility of the institution serving as the single IRB is IRB review, right? So they will do the IRB review, the continuing review, potentially, changes that we call them amendments here, but like changes to the protocol mid-year, like, all the everything that requires like the review of the IRB. And this is something unique about our regulations, is that that both of my colleagues mentioned earlier, the distinction between the administrative part that does administrative work and the IRB review, right? The IRB is the panel that reviews and approves the research. The office is not the IRB, right? The rest of the office is the administrative support that does a lot of the record keeping, like all those things, right? So anything that requires an IRB review, a review by the panel or an expedited review, that's the responsibility of the single IRB. And then, there's, I mentioned there's other responsibility that can be distributed among institutions. It depends like what arrangement works better for them. So.
Bárbara,
Holly, do you want to go?
Well, I sort of think of you as the expert here, Barbara, in terms of practically how the SMART IRB has sort of taken a lead in saying, here's what makes sense for the IRB of record to be responsible for. Here's what makes sense for the local IRB to be responsible for. And, back in the day, there was a lot of negotiation about that, but I think there's a consensus these days through the work of the SMART IRB that these are the general ways. There are always exceptions to the rules, but there's a standard.
Yeah, and happy to go through that. But just to clarify, there's a reviewing IRB and a relying institution. There is no relying IRB.
Thanks for that.
So just pop that out of your language, because the question is, what are the functions? Imagine an IRB is sitting around that table or virtual table now, and what are the institutional responsibilities? And that's what we're trying to get across. So the IRB, as Jaime says, approves, disapproves, requires modifications to the protocol as submitted. It is responsible for the language in the informed consent and making sure that all of the issues of consent that are explained in plain language, hopefully in a linguistically and culturally appropriate manner. All of those kinds of things. They're responsible for receiving the continuing review, reviewing when there's an unanticipated problem, serious adverse events, unexpected adverse events. And those are all the normal functions of an IRB, and they do them on behalf of all of the institutions. And they actually must be able to have a communication pathway that is well worked out. So when they make a decision, they communicate it to all of the institutions and sites that are relying on them. These are all incremental process steps, but like redesigning a system, once it's redesigned, it's not that hard. We're talking about process, not like new ethical formulations of how we think about research. And then the lead PI who has submitted to the IRB of record is responsible for coordinating much of the site information, much as they do for a coordinating center, or the coordinating center can do that with a lead PI working with them. And those are all sort of defined. The challenges come in with audits and non-compliance. Who takes responsibility? You've got an investigator at institution at a distance that you don't know. Who's taking responsibility for reviewing that event, what was known about the event, making sure that there's a corrective action plan and that correction action plan is executed? All of those are sort of the kinds of things that we hadn't anticipated to the extent that we have now. And now we have, because it was brought up as a problem, a way of dealing with it. But each time you think about it, there are levels of complexity. So now let's say that investigator doesn't have a problem with my protocol, but they have a problem with the other 3 that are being reviewed elsewhere. Do I need to know about that as the IRB of record for one of their protocols? Well, if we were in one institution, I would know. But now with the institutional, multiple institutions with IRBs reviewing, we might not know. And that's where having the institutional responsibility is so important, because they don't need to tell us as the IRB of record of an uninvolved protocol, but maybe they should if they think it's going to impact their performance on something that I have responsibility for. So for each of these situations, what we've tried to do is to take a step back and make sure that we've put in place the thinking to protect human participants and make sure that the data has the integrity at the end of that it's really generalizable and worthwhile, because it's, that's our job.
Solo una pregunta que está relacionada con lo que se
There's a
mencionaba
question here
del
that
seguimiento
ties
a
into
los protocolos
the
aprobados.
the follow-up of the approved protocols. The IRB communicates also with the national regulatory body, in the case of United States, the FDA, with regards to the protocol. Do they manage that kind of relationship with the authorities?
No, that is unchanged in the single IRB sense from the multiple IRBs or single protocol. The PI and sponsor has the responsibility for interactions with FDA. So the sponsor will usually be the holder of the IND or IDE in the United States. They have responsibility for that. The PI has responsibility for the conduct of the protocol and is directly responsible to the FDA. In fact, one of the problems, in my opinion, is that, and this is only my opinion, but since I'm not a government agent, I don't have to, is that the FDA does not have a direct relationship with the institution that is the employer of the investigator. They come in and do an inspection, they find many problems. Actually, they only have to tell the investigator, not the institution. And I think that's problematic, because no investigator is successful without their institution, and no institution can provide the oversight without the information.
Gracias por la aclaración. ¿Alguien más quiere
Thank you
opinar
for
sobre
that
este último?
clarification. Are there any additional comments with regards to this point?
Bueno,
I can speak for FDA, I'm sorry.
it's okay.
But we would
Bueno,
love you to.
seguimos con otra pregunta y tal vez esta
We have
no
another
sea,
question.
la última.
It might be the
Sin embargo,
last
otras
one,
formas,
but
que
we have
podrían
heard
evitar estas
of
duplicidades
other
de revisiones en los
means to
comités,
avoid the
aparte,
duplication
de
of
la
committee
adopción, ¿no? de la
reviews
política del single
other
IRB.
than the single
Sin embargo,
IRB option.
ustedes,
But you
¿qué recomendaciones darían
have
a
perhaps some
aquellos países de
recommendations
la
for
región de América
countries
Latina y
in the
Caribe
region,
que
Latin America and
están
the Caribbean,
planeando
who
adoptar
are
una
thinking
política
about
similar a
adopting
la
a
del
policy that
single
would
IRB?
be similar
¿Cuáles
to
son
the
los
single
puntos que
IRB.
deberían
So
considerar?
what, in your
¿Qué
view, are the
definitivamente
most
no hay que
important
hacer?
points
¿Qué
that they need
sí
to look
sería
into,
una
what should
buena
not be done,
práctica?
and what would be a good
¿Algunas
practice for them
opiniones
to
sobre ese
implement? Do you
punto?
have any views on this?
So,
I
yes.
I
and
have
it's
no end of
really
views, but I will defer to Holly.
I have all sorts of views on this topic that I'll just share a couple of ideas. So one, just to get us started as we're thinking about the single committee with the responsibility, I, Holly, have the opinion that having only one committee review a protocol has some downsides. While having 11 IRBs is too many, is one enough? And so the idea of collaborative review or a way to, again, regionalize is too strong, but identifying expertise that's available and identifying the individuals and the collaborators who might have some particular expertise that could be brought to the table, right? So if you imagine the average IRB, as Jaime can tell us, they are required to have adequate expertise to review the protocol in front of them. They have the option to seek out expertise. We've done, some colleagues have done some research that finds that IRBs seldom look for outside expertise. When they do, they usually try to find it within their own institution. I'd like to think that there's a way of having expertise that could be brought to particular types of research, or let's say pediatric research, because, you know, children are vulnerable, that there might be an institutional body that has responsibility, but there's some expectation that they're supplementing their expertise with individuals who have the type of expertise, frankly, even if it's duplicative of what's around the table. I just worry. I'm a big fan of collaboration. I'm a big fan of two heads is better than one. And one of my lingering concerns about the single IRB or single research ethics committee is that, you know, two groups looking at something might find something of value that leads to better protection of human subjects that just one committee might not get to. So I guess I'm advocating for a way in which to look for particular types of really complex research and think about collaborating in the review on that type of research versus, you know, more, I'll call traditional research. You know, as we learn new things, as AI comes on board, as we start transplanting animal organs into humans, there's always going to be something that's kind of at the edge of science that seems like focusing our attention on some of that and less of our attention on some of the more run-of-the-mill type of research might advance the cause, and having some collaborative, having a sort of standard way to collaborate. That doesn't really, I don't have one answer, obviously, about how you guys should be thinking about this, but I think I would say at least one thing, that it would be really important to think about what is the capacity of the country or region that you're in today, right? If you are in Peru, what is the infrastructure and resources like in Peru? And that may help you decide whether or not, well, there's a lot of expertise in Lima, but not a lot of expertise outside of Lima. How do we bring some of that expertise out or bring that rural expertise in? And this model might not be the best model for managing the ethics and protecting human subjects in that type of setting.
Jaime, do you want to continue?
I do have my reservations, and there's because of my work in the international population, I know that there's many countries that have one IRB for the whole country, right? I have my reservations with those things, which two primary reservations. First, that moral decision making is not objective mathematics, right? It's not like 1 + 1 = 2. So if you have only one committee, you're going to be the moral conclusion or the ethical conclusion will reflect the views and the values of only one committee, of only the people sitting in those committee, and has a Latin American native. I can say that in many of our countries, the people sitting in those committees are all the same class, the same race, and there's no actual representation of indigenous communities, of African American communities. So you're only like, it's only the things that matter to one committee what justifies the ethical conclusions, right? And my second issue with that is that as the time goes on, we need new members, we need rotation, like you're gonna end up with the same doctors. It's gonna be the IRB chair of the only committee for the entire country for the next 60 years. And it's like some kind of like IRB dictatorship, it's gonna the entire research infrastructure in the country is going to change to accommodate the views of this one person in power, right? So that's another concern that I have with the one committee. On the other hand, I do favor single committees for specialized research, right? Like a single committee for cancer research, a single committee for pediatric research, or any other kind of research that has vaccines that has very high risk. I do. I do like those to be a single committee. Those are very helpful to have all the experts in one room, right? When it comes to those.
And I'll just say, as a typical IRB type person, it depends. So I do think that we have to be very thoughtful about the kind of research that we're talking about when we're making these statements. And that I very much believe, as I think Jaime and Holly would agree with, in a risk-based approach to this. And that the expertise is incredibly important the greater the risk is of the research, which can be in many dimensions. It doesn't have to be, safety events, or it can be privacy, it can be dignity, it can be, but I do think we need to think about that. I totally agree with this issue of collaboration and of extending the moral reasoning beyond the functions of what the IRB is now constituted to do, because much of that is very practical and sort of routine and has become more and more routinized and less about those ethical discussions and sort of issues. We interviewed an IRB that does 70 protocols in 2.5 hours. Oh yes. I think we have to be very thoughtful about, sort of recommending one solution. And as I say, I agree completely with the idea that we should be understanding the context before we make recommendations. Yes. The one thing I will say, or a couple of things, I really have become a much stronger believer in the role of community engagement and community boards in pre-review before it even gets to an IRB or an ethics committee, to understand this contextual challenge, and make sure that the research that is being proposed is addressing a question that is of interest to the community and that the community has had a chance to weigh in on. And then I think some of the contextual pieces of what the IRB has to be guarded against or about diminishes if it's really gone through a rigorous engagement with that community with whom the research will be conducted. We don't do that for the most part, with the exception of it being part of the DNA of HIV and research. You would never get HIV protocols across the finish line if they did not have community advisory boards. That's now true, I think, of MDR-TB and a couple of others, but it's certainly not true of many, many other kinds of diseases and protocols. I also think there's a lot of research that really, student research, which is for some IRBs, the bread and butter of what they do is approving the protocols proposed by their undergraduate and graduate students as a way of teaching them about the methods of research. I don't think we should be worrying about that as much as we should be if we're implanting, xenotropic organs into, people. Or if you're asking somebody to do a vaccine and be the challenge vaccine, or a gene therapy or an implantable device where you've got one shot on goal. Those are the things I think we really need to make sure that they're reviewed thoughtfully, but also that we've made sure that there's participant understanding in what they say yes to.
Muchísimas gracias a nuestros panelistas. Muchas de las
Thank you
cosas
very
que han
much, panelists.
resaltado en su
Many of the
reflexión
things that you
final
have pointed out in these
resuenan
final
con el mensaje
comments
que la OPDC
are
da
in accordance
constantemente,
with
en el
a
sentido de
constant
que no hay una
PAHO
fórmula
message.
única.
That
No es
is, that
verdad
there
que
is
one
no
size fits all.
one
La
size fits
solución en un
all.
país como
The
Nicaragua
solution in a country
puede y
such
debe
as
ser
Nicaragua
distinta que la
can
solución en
and
un
must
país
be
como
different
Brasil.
to the
Creo
solution
que
in a
tenemos
country
nosotros
such
en
as
la región
Brazil. In the
bastantes
region, I think
desafíos,
we
no
face a
solamente
number
para
of
mantenernos
challenges,
al día
not only
con
to
lo
be
nuevo,
up
con
to
lo más
date with what
actualizado,
is new
sino también para
and
asegurar que
emerging, but
conforme se
also to
modernizan
make
nuestros
sure
sistemas de
that as
supervisión
our
ética de la investigación,
ethical research
avancemos de manera
systems
eficiente,
modernize, that we
construyendo
move
sobre la
forward
mejor
efficiently,
capacidad que
building on
tenemos
the best
y,
available
y
capacity,
alineándonos
and
cada vez más con los
being
estándares
more
internacionales. La
aligned
relación en
with
tareas entre
international
qué es
standards,
trabajo de
the
la
division
institución, qué
of
es trabajo
tasks.
de
What is the
de la autoridad
institution's work?
regulatoria
What
nacional,
does the
qué es trabajo
national
del comité de
regulatory
ética, en vez
agency
de
have to
que
do?
estoy
What does
acá
the
y resuelvo
committee
todo, porque
have to do
si bien
instead of
eso
me
hubiera
being
podido
here and
ser la
solving
solución
everything?
que
Yes, that
fue
could have
más
perhaps been
razonable
the most
hace
reasonable
algunos años,
solution several
parte
years
de nuestra
ago.
evolución, de nuestro
But part
progreso,
of our
debe
evolution,
ser
part of our progress
profesionalizar y
is
asegurar el
to turn
rigor y
more
la
professional,
eficiencia
have
de
greater
todas
rigor
estas
and
tareas.
efficiency in all of these
Queremos
activities.
nuevamente
Once again, let
agradecerles.
me thank
Creo
you.
que esta reflexión para
I
identificar
do
lo que
believe
en
that
inglés se
this
dice ese sweet spot,
reflection,
ese
finding the
punto de
sweet
balance entre lo
spot
razonable, lo
between what
eficiente, el
is
nivel
reasonable, what
adecuado
is
de
efficient, which is the right level
colaboración
of
y la
collaboration,
manera de calibrar lo
and
que se
how
hace
to
para los distintos
calibrate what is
escenarios
being
es
done
esencial.
according to the
Voy
different scenarios. That
gracias
is crucial.
nuevamente a
So
nuestros
once
panelistas,
again, I thank
a
the
nuestros
panelists.
intérpretes,
I thank
a
our
quienes nos dan el apoyo
interpreters
para realizar esta
who
sesión
support
y
us
por
in
supuesto a los
holding this
participantes.
type of meeting. And
Quiero
also I
reiterarles que
thank
antes de
participants.
vamos a despedirnos, pero voy a
We're going to
dejarlos
say farewell,
con
but before that, I want
una
to
diapositiva
share with
donde
you a
ustedes pueden
slide
ver, les compartiremos los enlaces
where you will find
a la
the
página web del
links
Programa Regional de Bioética,
to
donde
the
recibirán,
regional
pueden
bioethics
suscribir a
program,
nuestra
for
red de
instance.
investigación
There
ética
you
y
can sign
recibirán
up
por
to
medio
our
de esta
ethics
lista la
network, and
invitación,
thanks
no
to
solamente
this
la
list, you
grabación de esta
receive
sesión para
not
que
only
la
the
compartan con
recording
sus
of this
colegas,
session for you to share with your
sino
colleagues, but you
también
will
la invitación para
also
nuestra
receive the
siguiente
invitation
sesión de este
for our
webinar
next
compartido con
session
nuestros
of
colegas
this
de
shared
medicamentos y tecnologías,
webinar with our
que se
colleagues
llevará a
from
cabo el
Medicines and
25 de
Technologies to
septiembre
take
y
place on
será
September
sobre los diseños
25
adaptativos.
on
Otro
adaptive
tema difícil al que
design,
nos tenemos que
another
adaptar como
difficult
región. Muchas
topic that we need
gracias
to
y que
adapt to
tengan una
as a
buena
region.
tarde.
So thank you very
Gracias a
much
todos.
and enjoy the rest of the day.
Thank you.